77-year-old female with a past medical history of CAD, has had a stroke in the past back in 2001, but otherwise is pretty functional. Also has hypertension, hyperlipidemia, and type 2 diabetes, presenting to us with lifestyle limiting claudication that has been medically managed for a long time and now has progressed pretty much to rest pain. On the right leg, she had an ABI of 0.5, and on the left leg, she had an ABI of 0.7. And then we followed that up with some arterial ultrasounds, which showed that she had bilateral SFA occlusions, the right being a little bit worse, heavily calcified, and a total occlusion.
So we brought her in, and as you know, that being intravascular lithotripsy day, we were hoping to get a really calcified lesion, and I'm gonna have Ibrahim just go over the quick angiogram here. Can you guys go to the angiogram for us? Okay, and you can see here. Go ahead, Ibrahim.
So this is just a dry left coronary cine, just so we can show you how much calcium is actually in this SFA before we show you the flow down it. And you could see that there's a heavy amount of calcium throughout the SFA, and especially between the numbers of 20 and 25, we see a dense calcium. Coming from our sheath down to the proximal SFA, you could see that there's diffuse disease up in the proximal SFA until you get to a total occlusion around 15 with a large collateral over there, which is probably filling the distal SFA, which we'll see a little bit later. And then you have robust profunda flow, which is probably keeping the leg open at this time. And then over here, you get a better idea of the collateral flow to the distal SFA coming from the profunda, as well as that collateral coming right off the area where the SFA is occluded. And then as we go distally, we see a little bit of a lesion in the proximal pop in the P1 segment that's also heavily calcified. Luckily for us, below the knee, we have very good distal outflow with a 3-vessel runoff going to the foot.
So that's a great job, Ibrahim. So as you can see, we've got a significant SFA lesion. While they hook up the IVL, if you can see, we're a little overconfident that we're going to probably cross, which I hope we are. As far as the system that we've got right now, we've got a 7 French up and over system. Doesn't have to be a 7 French. We always do a 7 French because we do a lot of live cases. And with live cases, you need to have the ability to switch equipment or whatever it is as much as you possibly can. So now we're going forward. I'm just taking a steerable catheter, and I'm just going to ask Ibrahim or Ray to give me a woolly wire to put inside this to steer the steerable catheter into the. Can I get a woolly wire, guys? Into the superficial femoral artery. So for everybody, I think knows what a woolly wire is. It's obviously a floppy tip wire with a reasonable amount of body here. So as Ibrahim and I will just steer this in as Ray gets everything ready. The idea that we're going to try to do is to cross this intraluminally, which would be ideal. Not that we have any data to support one way or the other, but I think intraluminally will be a reasonable way to support this. You can see here, I got it, brother. We're just going to cross this, get this catheter and this sheath into that area and meet up with that distal, what is it called, occluded segment that we're looking for. You can see here that we're going to have to come back a little bit. So watch out for the IVL, Habib. So we're coming back now. Okay, you can see the calcium, the level of the calcium. That's the occluded segment right there. So my idea here is to park this at the level of the occluded segment. And what I'm planning on doing is demonstrating with one of our catheters called the Viance catheter. So the Viance catheter, if you can focus on my tip here, is nothing other than a little. It tries to find the fenestrations within the lumen of the vessel. As we all know, most CTOs, whether it's coronary or peripheral, closed by fenestrations. I don't know if you guys can zoom in on this catheter in my hand here, but this catheter basically is nothing other than a drill that'll actually superficially drill on top of the plaque, which will then allow for this catheter to find the fenestrations and pop through. So in the back we have a little torque device as well as a little spinner, which I'll be spinning here, which will allow me to go ahead and spin the catheter through. And for support, we're going to load what's called as a stiff wire. In this case, we're going to use an Asahi Confianza Pro to go ahead and be in there. Not that we're going to use that to actually cross the lesion, but we're actually going to use that to go ahead and give support to the catheter as we cross the lesion. So as you saw, it's not a very challenging, I mean, it is challenging because it's calcified, but it's not a terribly difficult cap, although calcified caps can always give a lot of trouble to us. So you can see here, we're just going to go down, and I'm just going to go and try to engage this cap with this. Let's see how it behaves. So there's the Viance catheter that's going into a collateral, you can see there. So I'm just going to twist it away from that, and then try, and that's why you want the steerable catheter as much as possible here. So let me go ahead and twist this a little bit and try to get this down if I can. Let's see how this thing behaves. There you go. That seems to be a little bit better. And that seems to be the cap, I think. Let's see. And with calcified lesions, is not that's the cap for us. So what I'm going to do is I'm just going to push this wire down to the tip, and then I'm going to have Ray just give a little positive on that Viance.
Was it crazy?
And hopefully it'll pop and find the fenestration. So it's sort of like a telescopic scopic system that's going to work. And it's a little bit more elegant, but again, it's very difficult in these heavily calcified lesions. You know, and I don't want to dissect this badly with a wire technique here. So I'm going to take it right to the tip, as you can see. Then I'm going to undo this and take this close and tie it up here. Then all I'm going to do is try to twist this here through. Let's see if it works. And there it goes. See, it's already popped. It popped somewhere. So Ray, advance that catheter a little bit for me. So see, there you go. It's trying to find the fenestration. That's fine, Ray. And now I'm hopefully at the level I want to be. Let's see. I think if we go to the last view, where is the occlusion come back? It's always good to look at our pictures to see what number it comes back at. Let's see. It's around 20 is what I thought. So we're pretty much across 15 or at 15 now. So let's see if it pops further. There you go. You see that? See how it's just trying to find the fenestrations? So now I'm going to just advance my wire closer. See, it's bouncing off the plaque there. And I think let's do a little roadmap here for us. So let's see how close we are. So we're pretty close. So let's see. Maybe we get in, maybe we don't. Let's see. Nope. So I'm not quite happy there. So at this stage, I've traversed majority of the calcified lesion very nicely. So this is a nice chance for me to try to use my wire to try to pop in this area here. I see I'm engaging right in that one spot.
Yeah, bouncing right out.
Right there. That's it. Oh, I thought I was in. Okay. So what I did was I went with the Viance trying to find the fenestration, which I did initially, and then we went ahead and used a what is it called? Can I get a new angle stiff glide wire, guys? And then we went ahead and used the wire techniques. When I started, I thought that the Viance might be enough to get through, but obviously it's not. So therefore, I think it's one of those things that it's really just by feel. Any other catheter do I think would work? No, I don't think any other crossing catheter would work this. I know people tried the Wildcat and the Kitty Cat and stuff like that. I don't think that would have worked in this case. So now what the problem I'm having is I'm not able to get parallel to the vessel. So I'm going to extend my dissection plane down by using an 035 wire, and then extend my dissection plane a little bit closer to where I need to be able to enter with this device. So what I'm going to do is I'm just going to go ahead. Hopefully this pops in, solves all our problems. So let's see. So now I'm going to go here, and it did. I think it just popped in. So exactly like I thought would happen, happened. So now we've crossed the lesion, I hope. You know, although I shouldn't be that confident, maybe I'm not. So let's see here. It felt like it popped in, but I could be wrong. So I'm just going to leave it at this level and see whether I can just direct my wire. Nope, I'm not in the vessel, that's for sure. Yes, I am. There I am. So we're in the vessel. You know, anyhow, we managed to get into the vessel, hook or crook, as my dad used to say, and so now we're in the vessel. So now we're just going to go ahead, advance the wire. That's a good sign. That means we're in the collateral. So hopefully we will be able to get in. Just give me a little digest so I'm not too overconfident. Inject. So let's get the IVUS ready quickly.
It's ready.
Yep, we're clearly in the vessel, which I'm happy with. So now, yep, there you go. So now I'm going to track this catheter down. Wow.
Oh,
There you go.
nice.
Okay, good. Now let's do the quick IVUS. Thank you. Pull back. So you can see with the IVUS, he's pulling back here. It's pretty much calcium dropout throughout. A heavily 360 heavy calcium. And you can see very, very tight lesions in every area. You can see as we're coming up now, we're around the area where we occluded, and you can see how calcified the vessel is. Keep coming. So we're going to keep pulling back, and you can see the vessel is probably, it's hard to measure it. It's probably a 5.0 or a 6.0, but I'm probably going to go with a 6.0 shock wave here. Heavily calcified, 360 degree. There we're subintimal. As you can see, and now we're back in the lumen there. There we're in the lumen. Come back. And then you can see right around 15. So give us a 6.0 shock wave, guys. Okay, walk it out. So now that we have this, we're going to go ahead and use our intravascular lithotripsy balloon to go ahead and crack this.
Do we need to 8?
So here's a regular balloon to 8 atmospheres. 7 and 8. It's undersized, obviously, so I'm okay with that down. Just want to make my channel. There you go. Now this is the area. Go up here. Okay, down. See how tight even this balloon is having trouble going. Okay, down. And okay, let's walk it out. So we're going to go with the, again, the shockwave balloon down. So Ibrahim, can you talk about the technique here?
So I'm going to go up to 4, and then once it's at 4, we're going to engage some of the vessel. Ray is going to deliver the pulses. So at each one of those dots, IVL or lithotripsy is being delivered, and the hope is to create some cracks in the calcium, and we'll see if we crack the calcium when I go up to a higher pressure of 6 or 8.
So our final therapy here will be a stent, obviously. I don't believe that a drug-coated balloon has any role in this kind of case. Our data from Jack shows that drug-coated balloons fail because of recoil. That's what the impact data set. They were kind enough to provide tremendous support for us to do that paper. So therefore, I think you have to put a stent. And here we're likely going to prep the vessel more and then place a Supera stent. I'm just putting positive pressure on my left hand as I deploy the stent slowly. Now that's just too much pressure, but now you can see now the stent is starting to deploy nicely. So which I will now put negative on my right hand and try to deploy the stent with a little bit more ability. And we're already there. Perfect. Okay, perfect. All right, get us a 5.0 balloon now, please.
You want the Vitrac if we have it?
5.0 Vitrac, please.
All right, going up.
10, 12, 14. Get down. Okay, I'm going to go up again here. What happened?
Nothing.
Okay, down. Okay, I just need to put a stent down and we're done. So we'll be done in a second. So we're just for everybody to know, we're just going to go with a 140 long Zilver PTX, which is a drug-coated stent. And I think we'll be done with this case. I just want to show this. And we are now going to deploy the silver. Ready, Rail? Take fluoro, please. Go to 25. So we're just going to cover that distal dissection plane at 25, right there.
You want to see where you are approximately?
Yep. Well, it's a long stent, so we should be plenty fine. As you can see, we're where we kind of want to be. There's actually a good size for us. So this one, you press the button in the back to release the lock, and then slowly just unwind it. As you can see, there's the unwinding of the silver. And like Ibrahim so nicely predicted, our vessel preparation has been quite good here, although we probably will have to post-dilate this. Okay, ready? Sandy? So there's that first lesion. The collaterals are both preserved. Everything looks really, really good. Here's the second area here. So you can see the little dissection up top. We'll check it with IVUS offline, but I think we should be okay. And I think we're gonna have to let that heal. And the final runoff here, just to show you the final lesion here, or the final runoff, to make sure our runoff looks good. So we started with 3 vessel, we're ending with 3 vessel. So I think it's a good sign. And so with that, we're going to sign off. I think it was a good case to show a CTO with all the complications that occur, and obviously with a very difficult calcified lesion, and the good work that lithotripsy helps us to do. So thank you, Ray. Thank you, Ibrahim. Thank you to our team, Reka and Habib. And we'll sign off from here. So thank you again.